this, and let me invite Dr. Sreeni Edakhlon. And finally, we all said there will be unhappy patients, and so by his looks, he will now impress us that he can make people happy. എന്നുള്ള ഒരു പേഷ്യൻ്റെ അടുത്ത് ഞാൻ എവരി പേഷ്യൻ്റെ ആസ്ക് എന്തെങ്കിലും ബുദ്ധിമുട്ടുണ്ടോ, സോ അത് പൈസയ്ക്ക് കുറച്ച് ബുദ്ധിമുട്ടുണ്ട് ഡോക്ടറെ. അപ്പോൾ ഇങ്ങനെ ചോദിച്ചാൽ ഡിഫ്യൂസ് ഹാപ്പിനെസ്സിന് മെനി റീസൺസ് ഉണ്ട്, അൺഹാപ്പിനെസ്സിന്. അപ്പോൾ വെദർ ഇറ്റ് ഇസ് റിലേറ്റഡ് ടു യുവർ സർജറി ഓൾസോ ഹി വിൽ ടെൽ us.
Thank you, Manu. See, I don't think I have much to say after all these presentations, but I'll try to make some sense into this presentation. So, if a patient comes with dissatisfaction after presbyopia correcting IOL implantation, the major reason is a residual refractive error. Dry eye, ocular surface problems, it is again a major issue. PCO, dysphotopsias, poor contrast sensitivity, Minu talked about IOL decentration, retinal macular issues and all. So these are the issues that are going to cause dissatisfaction. So accordingly, if a patient comes with dissatisfaction, you have to do a refraction, see how the ocular surface is, do a topography, see if there is an IOL, if the centration is proper, there is tilt or not. You might have missed something preoperatively on a retinal examination. So check that. So if the patient comes, do a refraction, and if you can correct the problem with refraction and trial lenses, then you have hit the problem there. See, I think Minu today morning was telling the patient, the other eye, the patient came, he has 6/9 N8, he says, I can't see anything. So he's actually comparing with the other eye. It's a comparison I'll come to later. But even if the patient is reading 6/6 N6 on Snell lens, the functional visual acuity won't be good enough for that patient. So studies have shown, we know talked about 0.5 diopter astigmatism. Studies have shown that if there is a 0.5 diopter astigmatism postoperatively in that patient, the functional visual acuity will be low. So that is something that you have to consider and manage. And unless you manage that, the patient will not be satisfied. So there is another issue. So patient comes, the patient is absolutely happy. Like same patient, 6/9 N8, absolutely happy. Your optometrist puts a trial lenses and says, oh, with this small power, you'll see much better. End of it. So they realize, okay, there is something wrong. So it's a balance that is there. So you have to be careful when you are you have to make your optometrists really understand not to become doctors as such. So that is another aspect about. So if what do you do if the patient has a refractive error? You have a refractive error, and you tell the patient. So don't do any intervention straight away. So give them a timeline. Okay, this is the timeline in which there might be adaptation, you will be better. And in this time, I'm going to do this. So if they're okay, you can give them some trial glasses, see if they are okay, but many of them don't really want it. So that is, so during that time, they'll get adapted, or they'll say, okay, this is what I have, but still some amount of dissatisfaction is there. So then you will have to manage. If still they are not okay, you might have to go for refractive surgery. Ocular surface is really, really critical. I don't know, at least in my hands, I see not very few patients who develop MGD after cataract surgery. You don't really assess on them. But if the patient is undergoing multifocal intraocular lens, then you have to doubly make sure that everything is okay. Treat MGD. If there is TH deficiency, you treat that. only after that you take up the patient for this surgery. Centration of IOL, Minu said about angle kappa and all. See, everything is done, and it's very difficult to go wrong. The centration has to be not on the optical axis; it has to be on the visual axis. If the patient can actually concentrate, you won't go wrong. But because of anatomical issues, it might shift, which is very, very, very rare. But if something like this, something related to the IOL, this thing is there, then you have to intervene early. And also the IOL related issues appear very early, unlike what is there with PCO. See, the PCO issues won't come in the first week and all. So if you have a problem with PCO, then don't do initially itself, it is not because of PCO. But in case of multifocal lenses, if they have a problem, see, recently I had a patient done about 5 years back, initially was happy, then somehow missed, went all around, talked about IOL exchange and all, then decided, then finally came back to me. There was a PCO, minimal PCO. I did a yak, patient is happy. So the point at which you're going to do yak capsulotomy in these cases, you might do it much earlier than with a monofocal IOL. And in case you feel that you have to do an IOL exchange later, you have to decide whether to do yak cap or not, because IOL exchange will be very difficult if you do a yak capsulotomy. The intrinsic IOL issues, glare halos and all, will be there from the start. So you would have already talked about that. You have to give time for adaptation. You can't do. So when should you consider IOL exchange? If there is persistent intolerable symptoms, significant tilt or decentration, uncorrectable refractive error, a macular pathology in which this is not going to work. So you will have to, roughly if you check the literature, it's about 1% of instances where it has to happen. So sir talked about communication. You have to start with empathy and reassurance, reassure that the symptoms are common, explain the recovery timeline, offer a structured follow-up plan as I explained. But the best way to manage is not to have a dissatisfied patient. I can't explain better than what Minu did in his presentation, address astigmatism, match. As JKS said, we are not creating a 20-year-old limit row. It is an older patient. So you can't expect that patient to have a visual acuity of 20 years, and they always compare between eyes, compare between what the neighbor had, their relative had. So all these expectations have to be handled pre-op. And one question I have to ask is, Minu said about who is best suited. Is an older lady, homemaker who is at home, the best patient for it? She's a person who has a lot of time and a lot of chance to complain. So I'm not sure that person. The others have a lot of work to do, and she has a lot of time to think about it and complain. So I'm not sure. We have to discuss. Thank you.